Thank you, Annette. It's a great pleasure this morning for me to be here and to kind of set the stage of the remaining days of the symposium in terms of the HIV epidemic that is currently going on in sexual minorities, MSM, and transgender people in the region. And I think the progress that has just been discussed is great, is fantastic, but there are people that are left behind. And we are in countries that have concentrated epidemics, but due to the great volume of population size, I think these epidemics are still very important to address, particularly in our region in Southeast Asia. There's a couple of things I want to go through in my presentation. So among MSM and transgender in selected countries, I will discuss recent HIV epidemiology. I will say a few things about HIV prevention and PrEP, and I will discuss the progress in the HIV service cascade, and then I'll conclude. The recent epidemiology in transgender women. Here are some data from integrated behavioral and biological surveillance in Indonesia. And you can see that these numbers, these HIV prevalence numbers across the island of Java, and in particular in Jakarta Metro, are extremely high. 34% of those enrolled in IBBS appear to be HIV infected. So these numbers, and you'll see many more of these numbers in the next couple of slides, but I'll tell you this, I think these numbers are just unacceptable. Here are some numbers from transgender women in Bangkok in Thailand, and you can see that the HIV prevalence has been quite steady over time. It didn't go up very much, which I think tells you something to what extent the Thai government and all its partners are working on controlling this epidemic in these populations. I have another one here. The HIV prevalence in transgender women in Kuala Lumpur in Malaysia is also of great concern. While nationally it's low, but if you look in 2014 and 2017, there is a strong increase between those two years, from 90% to 24%. Also here, 24% of the people HIV infected is just is enormous. So the recent epidemiology in men of sex with men. Here are some data from the Philippines in the Pacific, and you can see the what has long been called the sleeping epidemic to the left of the slide here. And then all of a sudden in 2010, things start to change. And these are the newly diagnosed HIV infections reported in the Philippines. They have an excellent reporting system because they have a central laboratory, and that's where they get all their information from. And they have done a really tedious and tenacious job in doing this from 1984 on to the present. So that's why we can follow this epidemic so clearly in this population. And the epidemic in the Philippines is a concentrated epidemic, particularly in MSM. And here you see the very steep rise of the numbers of HIV infection newly diagnosed in that country. In the beginning, you see a doubling, and then later on, it's every 2 years it doubles. And it looks very much, or it reminds me very much, and some other people in the audience too. In the beginning of the epidemic in the United States, we saw these doubling times. And it's over and over again we see this, and it's also a bit disappointing and maybe discouraging to a certain extent, but I'm not the one who's going to give up on this. I will continue. The daily number of infections reported in the Philippines on this slide, you can see now that, well, you can see that it increases very strongly over time, and that currently there are 32 new infections diagnosed in the Philippines, and 85 to 90% is in MSM and transgender and in Metro Manila. So there's really a crisis. I think there is a crisis going on in a situation where the government is distracted in other things and actually, should be moving in the direction of putting more effort in controlling this epidemic. There are steps, of course, but they go too slow. Now go back to Malaysia again, and also here we see a very strong increase in the number of new infections from 2009, 3.9 at that time, up to over 40% in 2017. So these are MSM in Kuala Lumpur, the metropolitan city of Malaysia. Again, these numbers are extremely high. Here I have a slide from Indonesia, also HIV prevalence from IBBS, and I'll just go down the numbers. 36% in Denpasar or Bali. It's now 32% in Jakarta, 28% in Bandung, 26% or 24% in Surabaya, 26% in Surabaya, 18% in Semarang, and 13% in Malang. And also you can see in this slide the increases that have occurred over the past couple of years from 2007 to 2011 to 2015. And then here is the long-term HIV prevalence from IBBS conducted in Thailand. We started this work in 2003 and found a prevalence of 17%, and it rapidly doubled almost within 2 years in 2007 to over 30%. Since then it has been more or less flat, and even in the last years, although it seems to be coming down a little bit, but it's still 24% in 2016. Now you have to imagine these are averages. So these are young people of under 20 years, 20 to 25, 30 and up. If you're 40 and up, and they're also in here, I'm not showing those data, but prevalence in people over 35 years of age, they have a prevalence of 50 to 60%. So if you just continue to calculate prevalence over time, by the time they're 60, 70, they're nowhere different from the prevalence rates we saw in San Francisco in the beginning of the 80s. 60, 70% of the gay men at that time were HIV infected. They have all passed away. Most of them, not all of them, but most of them, because the lack of access to treatment, which came really only in 1996. Here there is more treatment available, but it's more difficult to access. This is a slide from the Thai Red Cross Anonymous Clinic, and I'm grateful for Dr. Papan and Dr. Nitya to let me use this slide. Here you can see the blue bars. You can see the tremendous work that has been done in increasing HIV testing, and many more people, almost up to 14,000, have come in the past year for HIV testing, which is a great job. In the red line, you see the HIV prevalence, and it declines. And it probably declines, we think, because of many more people are coming in for testing. If you see in the bottom the orange bars, you see that the number of diagnoses per year actually doesn't change. So every year there are about 15 to 1,700 people that are diagnosed. The reason for this phenomenon, I think, is once people test positive, they won't come back. But what we are doing, because we're stimulating HIV negatives to come back every 6 months, so you see this increase in HIV negative testing, whereas the HIV positives are not returning because they go in another channel. So this weighs on, naturally this weighs on the HIV prevalence that you find. So I think this decrease in prevalence is more an effect of the numbers and increase in testing than it is an effect of a declining HIV prevalence or a lowering of the incidence. Now some data from the Siloam Clinic, Thai Red Cross's alter ego in Bangkok, so to speak. And we have been providing at the Siloam Clinic, we've been providing HIV testing and counseling since 2006, and you can see here the quarterly incidence since that time. Important to see is that it seems to peak a little bit in 2010 and 2011, and then there's a decline towards 2015, although not as steep as the one we saw at the Thai Red Cross data. What I do want you to note is the high HIV incidence in the youngest, 6.9%, And then in 22 to 29-year-old, 5.7, over 33%. And then actually is HIV incidence density, 4.8 overall. And so, although there is some decline, it may be the decline as a result of that we keep bringing in the HIV negatives, and then the HIV positive, actually they go in another channel for treatment, etc. But it's still, these incidence rates, particularly in the youngest, they're the highest seen among the world, and they're very concerning. Now, another friend that usually comes hand in hand with HIV is sexually transmitted diseases. And here we have the syphilis incidence during the same period. And as we've seen elsewhere, also here in Bangkok, in MSM, there has been a strong increase in new cases of syphilis being diagnosed. And it's reflected in this slide. And the syphilis incidence here, so the first episode, in the youngest is 4.9 per 100 person years, 22 to 29 is 4.8, and over 30 is 3.5. Overall is 4.4. So these syphilis incidence rates are very high as well, and of course it comes together with high HIV incidence because the two travel together. They're good friends, so then they mutually accelerate each other. Now another epidemic. So beside the twin epidemic with syphilis, we have an epidemic of methamphetamine use. And here is a slide from the Bangkok MSM cohort study. The cohort study recently ended, but we published a paper just last year looking at the incidence of methamphetamine and comparing it with the incidence of HIV infection. And you can see that the incidence in the blue dots of methamphetamine use continues to rise, and the HIV incidence in the blue dots rises even faster. Because I think there is a spin-off of this methamphetamine epidemic has a spin-off which is greater than methamphetamine, than the incidence of methamphetamine alone, because it infects people that are in circles where other people use MET, and so there is a lot of onward transmission from the MET population into the population that actually is not part of the MET use population. HIV prevention, I want to say a few things about that. And past year, we had a debate, and I call it the Brexit debate. So now you all know that there's nothing good coming from Brexit, and I don't know whether they have solved it already, but it's been a long, maybe some of the UK people here can tell me, but there has been a long and emotional discussion about Brexit. Last year we had this referendum, or we had this decision. We asked the audience, and people generally found that condoms were better to control the HIV epidemic than PrEP. Now, I like to question that, because there are no studies, scientifically, there are no studies comparing PrEP in one arm and condom in another arm, randomized, and then looking at the efficacy. Basically, I think we can't answer this question just like that. What we can do is looking at the efficacy trials of PrEP, where condoms were given to both arms. So there was condoms and placebo, and condoms and PrEP. So this is a slide from the IPRGA study, and I have another one here from the PROUD study, which was a waitlist controlled study, and people then rolled over once in the experimental arm. The effect of PrEP was shown. Also here, it was condom use and PrEP, or condom use only, but there was not a PrEP-only arm. So I think we can't really answer the question as it was stated at the time, but we voted nevertheless, similarly to people on the island in the North Sea, they voted nevertheless, but the government didn't know whether they could deliver, and I don't think we can deliver either. So the best way, I think, to end AIDS is condoms and PrEP. And I don't think we need to speak about or vote about a Brexit, because condoms and PrEP are co-joined at the hip, just like a Siamese twin. So let me go to the HIV service cascade. Here is the HIV service cascade for the general population in Thailand in 2017. And of course you need to realize this is work in progress as new numbers come in and we make progress, etc. Thailand has achieved in 2017 its first 90. They're still working on the second 90 and the third 90. And it's looking pretty good, I think, for the overall population. But now let's go to the same cascade for men who have sex with men. And I spoke at the beginning about people are left behind. So here we have a group that is clearly left behind in the overall development because there's no first 90 and we're nowhere near the second or the third 90. It's more like the first 20 and the second 10 and the third 10. So we're really not there. And of course, this is a point. I'll come back to this in my discussion. For the PrEP implementation, which is another thing, and here are a few other cascades, and I'm grateful to Dr. Nitya for providing me these slides from the Princess PrEP program. And here you can see overall retention in the PrEP program that is being implemented at the Thai Red Cross. In the left 6 bars. And then in the middle you see MSM, and on the right you see transgender. And you can see that retention over time is problematic. Looking at these different bars, you can see that it's difficult to retain people in these PrEP efforts, and we do not really know where they go, whether they go into another project, some may, or whether they just decide to stop it, or whether they have no longer risk. So it's difficult to say what is all behind this. But what we can see and compare is that when we look at transgender women only, it's worse. So in that population, the drop-off is quicker, and it's even quicker among the youngest. So in those at the highest risk for HIV infection, and you know from the Ceylon Clinic data, the highest risk for HIV infection in the youngest, but the loss to follow-up is there the greatest. So that's problematic, and I think as time goes by and the project is being implemented further, and my colleagues at the Thai Red Cross get their hands around it better, I think this will increase, but this is the situation. By the way, this is the only project in the region, and I think we should be, besides it shows us these problems, which is important. That's why it's important we have this project, and it can serve as an example and provide guidance to others who will follow in the region. Now looking at the adherence cascade in overall MSM and transgender, the blue bars are those who took their pills 7 days a week, so those are good. The yellow ones, they took 4 to 6 pills per week, so they're also protected, likely because 4 pills a week provides you drug levels that will fend off HIV infection. But then in the lower part, the red, green, and the dark blue, they are not doing so well. So the adherence is poor in those little subgroups. But you have to see this also in the background of the drop-off in retention. So there probably must be a formula of proportion retention times proportion adherent that you will get a better idea. Now, if we break this down further by age, you can actually see that the youngest, adherence in the youngest is the poorest. And this is the subgroup transgender women. So in transgender, adherence is less, and it's the least in the youngest. So we're making progress, and we're doing these things, and we're taking them forward. But overall, I think we still have an enormous amount of work to do. So I think that brings me to my conclusions. HIV prevalence and incidence continues to be high among MSM and transgender in Bangkok, particularly in the youngest, the most vulnerable. HIV prevalence is increasing among MSM and transgender in peripheral countries. The epidemic started here, and the solutions will also come from here, but other countries in the region are now in stages where they're seeing a strong increase in HIV infection in MSM and transgender. We are confronted with twin epidemics, mutually enforcing epidemics of syphilis and methamphetamine use. They come hand in hand. And of course, we need to think about control mechanisms. We are doing not very well in the HIV treatment and care cascade for MSM, and I think that is something we really need to work on as people are being left behind, and I've heard it several times, no one is going to be left behind in the 1990 approach, but clearly it's very difficult to realize, but we need to try. So the 1-year retention and adherence in the PrEP demonstration project is problematic, especially in young transgender women. Again, this is a work in progress, and we'll likely see in the future that this hopefully will get better. The twin epidemics, I already mentioned them, but finally, if we are not able to close the gap between treatment or treatment for prevention and prevention by PrEP, so if we can't bring those two antiretroviral components together closer, then I think we cannot control the HIV epidemic. So that is, I think, where our work needs to be. We need to do better in treatment, and we need to do better in rolling out PrEP. And if these two components come together, I think we'll be able to look at the epidemic in a couple of years in a very different way. Thank you very much.
Thank you, Dr. Frits. And if you could stay at the podium, we have a few minutes for questions. If anybody would like to go up to the microphones in the center of the room, if you have a question for Dr. Frits, before we break for coffee. While you're thinking about your question, maybe I can ask one to you. I found the beginning of your talk, of the epidemiology slides, showing literally a doubling of infections among MSM in Manila, in Jakarta, in Kuala Lumpur, alongside the incidence data that you showed in 18 to 21-year-olds right here in Bangkok, being double that of all the other groups, to be particularly concerning. And this sense of not only is AIDS not over, but as has been mentioned by a previous speaker, by Dr. Hill, that Asia could potentially be looking at numbers like Africa in the future, given our denominator population, and Asia continuing to fall behind Africa in almost all metrics as a region. Do you have any comments to share about that?
Yeah, no, I certainly agree. I think it's important to note also on the part of the AIS and other international organizations and those who organize conferences, that it is important to include a substantial role for Asia in your programs. And as said, we have concentrated epidemics, but because the population sizes, we may actually produce the same numbers as elsewhere in Africa. So I think in its right, I think we deserve the attention we need, just like all other countries and populations that are affected by the HIV epidemic. And no one, and also we should not be left behind.